The Ferrule effect. The incorporation of the concept of ferrule or the Ferrule effect has been accepted as one of the foundations of the restoration of the endodontic treated tooth. A ferrule is defined as a 360-degree metal collar of the crown surrounding the parallel walls of the dentin, extending coronal to the shoulder of the preparation. The result is an elevation in resistance form of the crown from the extension of dentinal tooth structure. The following definition was provided by Sorensen and Engelmann. So here in the diagram is an endodontically restored tooth which is covered by a crown, the center composed of the core. In the root canal is extended the post, and in the apical region is the gutta percha, and a metal collar seen in the cervical region marked by the red circle is the ferrule. The origin of the term is thought to come from the Latin terms ferrum, which means iron, and viriola, which means bracelet, such that the ferrule is an encircling band of cast metal around the coronal surface of the tooth. In the image here, you can see this is a water pipe fitting with a metal ferrule. So there's a metal ring which is present at the end of the pipe. Main function of the ferrule is to hold the structure of the pipe so that it does not collapse. Earlier, it was thought that the remaining amount of sound dentin above the finish line corresponds to a ferrule, but it is a misinterpretation as the ferrule is formed by the walls and margins of the crown, and it is an established rule that 1.5 to 2 millimeter ferrule height directly above the margin improves long-term survival of endodontic treated teeth with the post and core. So the ferrule acts as a metal band which braces the tooth and provides resistance to dislodgement and prevent fracture. So why do we need a ferrule? What is its significance? Root curvature, furcations, developmental depressions, and root concavities are observed at the external surface of the root, which are likely to be reproduced inside the root canal. Within the same root, the shape of the canal will vary between the cervical level and the apical foramen. As a result, severe alteration of the natural shape of the canal is often necessary to adapt a circular post inside the root. This increases the risk of root perforation, especially in mesial roots of maxillary and mandibular molars that exhibit deep concavities on the furcal surface of the mesial root. The tooth is also weakened if root dentin is sacrificed to place a large diameter post. And when properly placed, ferrule reduces the incidence of fracture in endodontically treated teeth. So the advantages of incorporating a ferrule are: it reinforces the tooth at its external surface, so it acts like a band which embraces the cervical portion, which is the most vulnerable region of the tooth, and retains its structure. It dissipates forces that concentrate at the narrowest circumference of the tooth, that is, in the cervical region. It promotes hugging action by holding the circumference of the tooth. It prevents shattering of root as it enhances the resistance feature, so it aids the tooth in withstanding the forces, thus preventing the root from fracture. It reduces the wedging effect of a tapered dowel, so it enhances the resilience of a dowel, thus preventing the wedging effect. It resists functional lever forces and lateral forces exerted during dowel insertion. And all these features help in improving the overall resistance of restoration. Ferrule basically combines a shoulder preparation with parallel coronal dentin walls. Moving on to the design of ferrule, how it should be made. Ferrule walls should be almost parallel to each other so that they are better able to withstand the leverage forces. The height of the ferrule should be about 2 millimeters and width a minimum of 1 millimeter. Now, while preparing a ferrule, care should be taken that the design of the ferrule should be in accordance with the shape of the tooth. So it is not just prepared like a horizontal pillar, but it conforms to the anatomy of the tooth, wherein the minimum height of 1 millimeter should be maintained. A bud joint margin should be present between core and tooth with minimal taper. Now let's look at these points individually. The height of ferrule. Greater the height of remaining tooth structure, better the fracture resistance. It was found that a ferrule of 1 millimeter of vertical height successfully doubled the resistance of fracture versus teeth without a ferrule, and appears to be the minimal acceptable amount of ferrule height. Now the crown portion should encompass at least 2 millimeters past the tooth core connection, that is, above the ferrule there should be at least 2 millimeter of the crown present to achieve the most protective ferrule effect. The height of the ferrule can be measured using a periodontal probe with a stop and an endodontic ruler. The width of ferrule should be at least 1 millimeter. Aesthetic restorations often require fairly aggressive preparations at the gingival margin, and sometimes buccal defects such as abfraction may compromise the buccal dentine wall. It has been accepted that the walls are considered too thin if they are less than 1 millimeter in thickness and would negate the ferrule effect. The width of the remaining dentinal walls can be measured using calipers. Ferrule location. A circumferential ferrule would be optimal, but caries may affect the interproximal areas and abrasion or erosion of the buccal walls. A crown preparation will further reduce the wall thickness and only a partial ferrule will remain. According to the literature, good palatal ferrule is as effective as having a complete all-around ferrule, or having a 3 millimeter ferrule on the buccal aspect was better than having no ferrule at all. The type of tooth. Anterior teeth are loaded non-axially. Posterior teeth are located occluso-gingivally. Anterior teeth with a deep overbite and parafunction are at a higher risk of failure. Teeth that are in groove function with long maxillary buccal cusp produce higher lateral forces than if there was canine guidance. Type of post. Repairable fractures are seen above cemento-enamel junction, that is the CEJ, horizontal cervical fracture, core tooth fracture. Repairable fractures are seen with fiber-reinforced post and 2 millimeter ferrule. Non-repairable oblique fractures are entirely below CEJ, fracture in the middle or apical third of the root, and vertical root fracture are non-repairable fractures. These non-repairable fractures are more common with cast double post and 2 millimeter ferrule. Another point of consideration when designing a ferrule is the biological width. So here you can see an image of the tooth and the gingiva. The free gingival margin encircles the gingival sulcus. The part of the epithelium attached to the tooth is the epithelial attachment, and below that is the connective tissue attachment, ends at the alveolar crest. Biological width is the dimension of the junction of epithelium and connective tissue attachment to the root above the alveolar crest. So in a prepped tooth, the distance from the prep margin to the alveolar crest should be at least 2.5 millimeters. That is, the ferrule should be at least 2.5 millimeters above the alveolar crest in order to prevent impingement to the bone. This implies that in case of a grossly destroyed tooth, first we need to assess the distance of the ferrule to be designed and the crest of the alveolar bone. If that distance is at least 2.5 millimeters, then a ferrule can be planned. Otherwise, alternative treatments need to be planned. In a tooth restored with post and core and a properly designed ferrule, the measurements would be as follows. The length of the gutta percha till the apical region would be about 5 millimeters. The post would extend from the region of the gutta percha to the base of the ferrule, which would be about 5.5 millimeters. The ferrule would have a height of 2 millimeters. The core extending from the apical region of the ferrule to the region of the crown would be about 1.5 millimeters, and the height of the crown over the core would be 2 millimeters. So before placing a ferrule, these measurements are to be assessed, and if found suitable, a ferrule can be prepared. In the article, Rethinking Ferrule, a New Approach to an Old Dilemma, the authors Zotkovic A. and Simit N. proposed a classification for ferrule based on 4 aspects, such as the height of remaining dentine after tooth preparation. A wall is considered to contribute to the ferrule only if it is 2 mm of height and continues along more than half of the tooth surface. The thickness of remaining dentine after tooth preparation. A wall is considered to contribute to the ferrule only if it is 1 mm thick. And the other 2 aspects being the number of remaining dentine walls and their location. Location is represented by corresponding side and the lateral vectors of load on the tooth, which are defined as light lateral loads or heavy lateral loads. Based on these four aspects, there are 5 categories. Category A, no anticipated risk. Category B, low risk. Category C, medium risk. Category D, high risk. And Category X, where no ferrule can be established. Category A, where there is no anticipated risk involved, sound dentine walls remaining all around the tooth with height greater than 2 millimeters and with a minimum thickness of 1 millimeter. Such teeth do not present an anticipated risk for structural or mechanical failure. Category B involves low risk. They are compromised or no ferrule present on either proximal surface that is less than 2 millimeter height and or 1 millimeter thickness, or 2 compromised proximal walls on a tooth that undergo light lateral loads. Such teeth present low risk for structural or mechanical failure. Category C, medium risk. 2 compromised proximal walls on a tooth that undergo heavy lateral loads, or a compromised buccal or lingual wall on a tooth that undergoes light lateral loads. Such teeth present medium risk for structural or mechanical failure. Category D, high risk. A compromised buccal or lingual wall on a tooth that undergoes heavy lateral loads, or a compromised buccal and lingual wall or on any tooth, or a tooth that has only 2 adjacent walls or only a single wall remaining. Such teeth present high risk for structural or mechanical failure, and alternate treatment modalities should be considered and may be more appropriate. And the last category is category X, where no ferrule can be established such that the tooth is non-restorable. And lastly, crown lengthening versus forced eruption. Now, there are certain conditions wherein the tooth is severely damaged and there is no clinical crown left to prepare a ferrule. In such cases, we are left with two options. Either the crown can be surgically lengthened or the tooth can be extruded via orthodontic forceps. The disadvantages of surgical crown lengthening treatment are an increase in crown root ratio caused by the reduced effective root length and the increased effective crown length and reduced volume of root dentine that remains. An alternative approach to treatment could be an orthodontic extrusion. Now, from the biological point of view, when orthodontic extrusion is performed, bone support reduces, but the coronal liver arm does not change. So the preparation of 1 millimeter ferrule after simulated forced tooth extraction significantly improved the fracture strength on the tooth. Lastly, the aspects considered of prime importance when preparing a post and core are the height of the ferrule, its width, the number of walls remaining and their location, and the degree of lateral load placed on the tooth. It is of utmost importance to remember that other less invasive restoration types should be considered so as to be able to preserve as much sound tooth structure as possible when restoring severely broken down teeth. This is of particular value when the remaining axial wall dentine thickness is compromised. I hope you have liked this presentation. Please do like, share, comment, and subscribe to the channel. Thank you.